Good morning. My name is Kelly Martin, and today I'm presenting my formal paper, The Relationship of Obesity and Depression. It is an epidemic that we are facing in America and starting to see it around the world. Today I'll be sharing with you the presentation, and we'll open it up at the end for any questions. So we're seeing the relationship between depression and obesity. In America today, we are facing a mental health crisis. We're seeing it in so many areas. We're seeing it with anxiety, we're seeing it with depression, and we're seeing the result of that manifesting in so many ways, whether it was violence, increased suicide, increased addiction, whatever that may be. We, as providers and practitioners, have an obligation to the general public to step in and see what we can do to help mitigate this crisis. The other crisis we are facing as Americans specifically is obesity. We're showing statistics that over 15 million Americans are considered obese. That statistic, honestly, I think is underreported. That is going specifically on definitions that we will get to in a moment. With these two that we're seeing, both mental health and obesity, our patients are becoming increasingly complex with more and more and more comorbidities. And that has presented a challenge to the practitioners, providers of the world to not only approach this from a multidisciplinary aspect, but to look at the patient as more than just one diagnosis or 1 to 2 problems. Starting with some definitions. The general definition of obesity is defined as having a BMI or a body mass index greater than or equal to 30. And that's kilograms per meter squared. Now, that's not saying much. I personally have a BMI of 30, and that's after losing a significant amount of weight. So, our patients can often meet this criteria with not necessarily fitting the visual aspects of an obese person. So, it's very important to look at our whole patient and see what they're showing and where they're showing it. Depression. Depression is defined as having depressive symptoms on most days, and that is using self-reported patient health questionnaire 8 of the mental health categories, as well as a clinical diagnosis by a healthcare practitioner. That's a kind of a broad description. In most cases, we have the diagnosis by the healthcare practitioner, but not everyone is using the self-reported system. And we'll talk about screening tools a little more as we go on. I wanted to discuss the relationship of depression and obesity. The two are considered to be a bidirectional relationship. And what that means is one doesn't necessarily cause the other. It can go in either direction. We haven't been able to easily describe and define this relationship. Having one does not guarantee that you will have the other. However, we are seeing that those with the diagnosis of obesity are more likely to have a diagnosis of depression. It is, in fact, the most frequent found mental comorbidity of the individuals suffering with obesity. Depression and obesity do exist independently of each other. Both are growing in severity and frequency, and we're finding that half our population is suffering from one or most often both of these. It's not easy to say which came first. Could we say that did the depression come first? First, the mood changes occurred, and then because of the mood changes, we have emotional eating, and because of the emotional eating, we gained weight, and then the self-esteem dropped, and because the self-esteem dropped, the emotional eating continued, and we created this cyclic type thing. Or did we have a weight gain, and because of that, we started to have decreased self-esteem and then the behavioral changes that accompany that? Because of the obesity, we also have less physical activity. So between the physical activity and the increased caloric intake, this drops the self-esteem, and now we're in that cycle. It's not easy to say which direction it is. We are not seeing a direct link between the two, but we are seeing some negative behavioral patterns that show up with both. We are seeing that higher instances of emotional eating are shown with those with higher BMIs. We're seeing sedentary lifestyles with obese patients, sedentary lifestyles with depressed patients. So the two of those can often go hand in hand, and they become a vicious cycle together. Let's discuss some variations and trends. We do know as a practicing body that socioeconomic status has great effects on both depression and obesity. Lower socioeconomic status is linked with greater rates of obesity, and those emotional life stressors that accompany the lower socioeconomic statuses can have great effects on the emotional responses, the physical activities, and also the dietary options available to those persons. Let's discuss gender differences. Women are more likely to experience both depression and obesity at greater rates and severity. As to why exactly, we don't necessarily know. We do know that women tend to have emotional, negative behavioral changes as it comes with their mood and their displays of behaviors. They tend to overreact as a reaction to weight gain, and they can almost often have poor emotional status, and with that emotional status comes the negative behaviors. Men are diagnosed with depression at half the rates of women, but they're diagnosed at similar rates of obesity. Some people think that this is kind of easy to figure out. Obesity is a predefined, very specific weight and height gives BMI, so it's concrete. Whereas the self-reported depression has to come with sharing emotions. Men don't report the same symptoms as women, so those symptoms may not be on those screening tools that we are utilizing. Those are things that we need to think about as it changes how we acknowledge our patients and how we treat those patients. We also see racial variations. We are seeing that non-Hispanic white women with depression have a greater propensity towards also being obese. Caucasian patients are demonstrating significantly higher rates of obesity and depression than Hispanic or African American groups of the same age demographics. One theory is that the screening tools that we use are not the screening tools that are culturally appropriate for all areas. Some cultures do not express emotions the same way, and those lack of expressions and lack of interactions with the healthcare team can affect how we diagnose and also how we treat. So, what is the role of the nurse practitioner moving forward? Moving forward, we as a practicing body should work on screening tools that fit the patient. This screening tool may not be appropriate for a male, it may not be appropriate for an African American. We have to look at both gender and cultural variances that demonstrate all of our needs. There is not a perfect tool for every patient. We have to look at the multiple disciplinary approach to care. We cannot just treat the patient with a pill and a visit. Do they need spiritual guidance? Do they need mental health guidance? We have to look at the whole team and the patient as part of the team. In conclusion, the relationship is a bidirectional relationship that is complex and as vast as the patients who suffer with them. This is not an easy task for us to tackle, but I feel that we can. Thank you. And if there's any questions, I'm happy to answer those.